Hi, this is Brian Kim. I'm going to share with you case number 16 in the best way to do cataract surgery series. This is a small pupil with a 2+ dense lens. I'm going to show you the double chop, cross chop, mechanical fracturing techniques, and doing the cortical sweep and flush, and lastly an i-stent. So I make my corneal mark to help me center and size my rhexis. I make my paracenteses on each side. I'm injecting intracameral lidocaine and epinephrine to see if I can dilate the pupil. And then I'm injecting dispersive viscoelastic. The pupil is getting a little bit bigger. I keep my cannula in the eye, and then I make my triplanar corneal incision. I make a vertical groove in the tunnel and then enter the anterior chamber. I place my rhexis forceps. I do a puncture technique. I puncture with the rhexis forceps. I pull down slightly on the left side, and then I turn a little bit to the right to create a little bit of a C-shaped flap. I grab and re-grab and trying to follow my corneal marks to help me center and size the rhexis. I'm making sure I'm not burping too much viscoelastic as I go around, and I'm able to get a nice, well-centered and round capsular rhexis. I proceed with my capsular fornix hydrodissection technique. I place the cannula out to the equator contra-incisionally, going underneath the anterior capsule. Once I get to the equator, I rotate the cannula tip 90 degrees downward towards the nerve. I get a very nice fluid wave in the process of doing so. And then I burp on the left side, and then I gently spin on the right side, and you can see this lens is spinning very nicely. I start with my phaco, but before doing that, I lift the incision with the chopper and go in with irrigation off to minimize Descemet's trauma. Once I get in completely, I start removing the surface epinuclear material. I do my double chop technique. I place the chopper out to the equator, making sure I'm underneath the epinuclear material. That is my landmark. That is the shelf that I'm going to use. I go underneath the epinuclear material, slide the chopper out with the leading edge being the tip. I rotate and supinate my hand, and I make sure I get down into the capsular fornix. I turn the phaco tip more vertically and subincisionally. I bring both instruments together, crushing the densest and most central portion of the lens, and the lens crushes and divides very easily. I place the chopper out to the contralateral equator, again, making sure I'm underneath the epinuclear material. I rotate my hand 90 degrees so the chopper is facing down, and then I pull the chopper centrally towards my stationary phaco tip in the middle, and I'm able to crush the right heminucleus. I perform successive mechanical fracturing techniques and maneuvers where I'm taking the chopper out to the equator and then crushing the lens between the chopper and the phaco tip, placing the phaco tip in the middle of the bag underneath the lens material to make sure I'm able to sandwich the girth of the lens material with each mechanical fracturing maneuver. Once the pieces are in small enough pieces, I pulse it with some vacuum as well as ultrasonic energy. And you can see this 2+ dense lens in the context of a small pupil went fairly easily. I remove my epinuclear material. I use my chopper to lift the epinuclear material away from the PC, and then I'm able to get a very nice removal of the epinucleus doing this technique. I'm flushing some of the epinuclear material with my cannula, and then I go to my IA. I am starting subincisionally. You can see there's not much cortical material in this case, and I'm going to sweep underneath. In these contexts, again, when I don't have good peripheral view, I am afraid that the INA tip, rather than grabbing cortex, may grab the capsule and actually pull on the capsule and thus the zonules. And so I like to switch to the polish mode and be very gentle sweeping. I notice that with the polish mode, even if I am sucking on the capsule, so it won't cause a capsule to be grabbed by the INA and cause zonular damage. So I like to do the polish mode in the small pupils when I can't see my tip. And then I'm polishing the posterior capsule. And then I'm going to use BSS cannula, and I'm flushing the subincisional capsular fornix to see if there's any cortical remnants. In the process of doing this, I think I see a little bit something there, but again, I'm not really confident there's anything in this area. I'm going to switch to the viscoelastic and pushing some cohesive viscoelastic in the bag, and I do notice now that there is some more cortical material subincisionally, and so I'm using the sweeper to help me tease out the cortical remnants from the incisional capsular fornix, and you can see this is coming out quite nicely. I inject the one-piece acrylic intraocular lens into the capsular bag, but I notice I can't see the edge of my rhexis, so I'm injecting the one-piece lens into the bag, and then I'm using the Maltzman to retract the pupil iris so that I can see and confirm that the lens is indeed completely in the bag. Once I'm completely in, and then I go underneath the lens optic, making sure that both haptics are released. I tilt the optic and then rotate the lens 90 degrees clockwise. And what I do is I tilt the lens such that I can make sure I get between the lens and the posterior capsule, but then by pushing it a little bit away from me, I'm also making sure that both haptics are within the capsular fornix. I like to use this Maltzman instrument sometimes just to make sure that both haptics are completely in the bag. And in this case, I have an i-stent, so as I come out with the eye in a handpiece, I push BSS, and then I inject the eye with some more dispersive viscoelastic. I want to turn the head very far away from me and rotate the microscope in such a way that it allows me to get a better view of the angle. And this technique is really kind of a stab first through the trabecular meshwork and then flatten out and make sure you're parallel to the trabecular meshwork. Once you've flattened out, you can advance and you can see you get a very nice positioning and sliding of the i-stent. You can see a trail of blood, and that usually confirms that you're in the right position. I usually like to tap it and kind of strum the i-stent to make sure it pops back into position. And usually this is a good indication your i-stent is in good position. So I'm going to remove my viscoelastic. I go in with irrigation off because I don't want to, again, push fluid against Descemet's and strip Descemet's. And I remove viscoelastic from underneath the lens and also in the anterior chamber. And then I hydrate my incisions. So again, this is a case of a fairly small pupil. As you can tell for all of my cases, a small pupil doesn't really change how I do my lens disassembly because I know that with my technique, I'm going underneath the epinuclear material as I slide out. Therefore, I am never over the anterior capsule. Therefore, when I do the chop maneuver, I am not going to cause a zonular dialysis or dehiscence. And when you confidently get underneath the anterior capsule, underneath the epinuclear material, you can do mechanical fracturing, placing your chopper out to the equator, doing mechanical fracturing forces to crush the lens pieces between the chopper and the phaco tip. And in my mind, this is the best way to do cataract surgery. I hope this was helpful to you, and thank you for your attention.